Representative Scott be allowed to join our subcommittee and be allowed to sit at the dais in order to participate in today's proceedings. Hearing no objections, so ordered. You may sit. Never had an opportunity to do that, so. As a 24-year Army veteran, physician, and a former nurse, I strongly believe that veterans deserve the utmost quality in care. I actually met my husband, Kurt, who was an LPN at the time, while we were both serving at Walter Reed. Having served in these positions both as a student nurse, married to an LPN who became a BSN nurse, and a doctor, and then the former director of the Iowa Department of Public Health, which had a lot to do with licensure and scope of practice, I believe I have a deep understanding of providing safe and effective care, and it remains one of my top priorities in Congress, and to ensure that veterans receive the same quality care as those seeking care in private hospitals. The VA issued an interim final rule known as the Federal Supremacy Initiative in 2020. Through this initiative, VA is working on establishing national standards for over 50 healthcare occupations, regardless of state scope of practice laws. VA has stated standardizing a set of practices that healthcare providers can perform within the federal VA system would help when needing to transfer care workers between different VA medical centers, depending on where care is needed most. While I don't argue that this might provide some greater uniformity within the VA clinicians of all types are able to move quickly throughout the VA system during the pandemic when critical needs arose in certain localities. Although this interim rule was published approximately 2 years ago, VA has not yet considered or opened up a comment period for a majority of healthcare occupations. It remains a concern to me and many other members on this committee that the VA has not been clear and as engaged about some clinical specialties, specifically specialties that require a significant investment in training and practice to ensure patient safety and board certification. It's imperative that the VA is transparent about this process and standards to avoid confusion among providers and patients, especially when there are wide variations in state licensure laws. During today's hearing, I look forward to examining the process and development of these standards. Additionally, I'm eager to better understand how these standards will affect patient care in the future. I want to be clear. I'm not here to play one profession against the other. I have the utmost respect for every clinician who devotes their life to the care of patients and especially of veterans. With that, I yield to the Ranking Member Brownlee for her opening statement.
Thank you, Chairwoman Miller-Meeks, and thank you for holding today's hearing to examine VA's ongoing National Standards of Practice initiative. As the Chairwoman just said, let me also say, and because I want to be clear as well at the outset of this hearing, that I hold the utmost respect for all of the dedicated healthcare professionals who work at VA medical facilities nationwide, including all the physicians, nurse practitioners, physician assistants, CRNAs, optometrists, and other healthcare providers. They show unwavering commitment day in and day out to caring for veterans, and their contributions to VA healthcare systems are invaluable. However, as we embark on this examination of VA's National Standards of Practice initiative, it is imperative that we consider the unique needs of veterans, many of whom have extreme and complex needs and unique medical conditions resulting from their service. Ensuring that veterans receive the highest level of care demands a thorough evaluation of the roles, responsibilities, and training of all healthcare providers within the VA system. I firmly believe that physicians with their extensive medical training and clinical experience play a pivotal role in providing comprehensive care for veterans, particularly when it comes to complex medical conditions, surgical procedures, and advanced treatments. My own son is a physician, so I have observed firsthand the tens of thousands of hours of intense study and training it takes to become a physician. Veterans, like all Americans, deserve access to the full spectrum of medical expertise available to address their healthcare needs. Throughout this hearing, I look forward to engaging in a constructive and fact-based dialogue to better understand the implications of VA's National Standards of Practice initiative on the quality of care provided to veterans. Together, we must ensure that veterans receive the highest standard of care and that their health care needs are met by providers with the appropriate qualifications and expertise. I look forward to continuing the discussion we began at a closed-door roundtable this past April, where we heard from each of the organizations represented on our first panel of witnesses today. At that time, stakeholders representing physician groups expressed frustration about what they viewed as a lack of transparency and engagement by VA. They said they had sent letters that had gone unanswered, and that they had not had meaningful opportunities to engage with VHA officials involved in the National Standards of Practice initiative. I've heard that the VA has made a greater effort to engage these groups in the ensuing months, and that is something I hope to hear more about today. One thing I brought up at the roundtable, which I still do not feel has been thoroughly addressed by VA, is why, given all of the other priorities competing for the attention of senior leadership, the department has chosen to undertake this initiative. We're already approaching 3 years since the start of the National Standards of Practice initiative without VA having finalized standards for any of the 51 occupations yet. If there was truly an urgent need to undertake this process, one would think more progress would have been made by now. I hope today's hearing will shed more light on VA's justification for undertaking this long, drawn-out process to develop a national standards of practice. I thank all of our witnesses and colleagues for their participation and candor in this crucial discussion. And with that, Madam Chair, I yield back.
Thank you, Ranking Member Brownlee. I would now like to introduce the witnesses. On our first panel, we have Dr. Jesse Ehrenfeld, President of the American Medical Association, Dr. Paul Barney with the American Optometric Association, Ms. Janet Senor, President-elect of the American Association of Nurse Anesthesiology, Dr. Stephen McLeod, Chief Executive Officer of the American Academy of Ophthalmology, and Dr. Ron Harder, President-elect of the American Society of Anesthesiologists. Dr. Ehrenfeld, you are now recognized for 5 minutes to deliver your opening statement.
Good morning, Chairwoman Miller-Meeks, Ranking Member Brownlee, members of the subcommittee. Thank you for having me here today. My name is Dr. Jesse Ehrenfeld. I'm a practicing physician and president of the American Medical Association. I'm a former Navy commander. I have a background in military medicine. I am on the faculty of the Uniformed Services University, deployed to Kandahar, Afghanistan during OEF. You know, I can choose to get my own health care pretty much anywhere I want. But for the past 7 years, I've chosen to get all of my medical care at the VA because I believe in the VA, its people, and what it can offer. So the implementation of these national standards of practice is a very personal issue. This project concerns me because I believe that our nation's veterans, my shipmates, will receive lower quality of care if this project is implemented. In medicine, our goal is to match the expertise of the person delivering the care to the needs of the patient receiving the care. It's why at our busiest downrange facilities, which handle the most complex injuries in battle, the DoD sends physicians to lead care teams. It's why today, when a patient having cardiothoracic surgery at the VA, they receive their care from physicians who lead the care team. However, the Supremacy Project will make it next to impossible for the VA to match the most qualified clinician with the needs of the veterans, potentially allowing non-physicians to perform procedures that are beyond their scope of knowledge and state licensure. This is concerning because expanding the scope of practice for non-physician practitioners increases costs and jeopardizes patient safety. The VA evidence-based synthesis program found that there was no evidence to support the safe implementation of nurse-only models of anesthesia care. A study in the National Bureau of Economic Research compared the productivity of independently practicing nurse practitioners and physicians in a VA emergency department. The study found that nurse practitioners use more resources and result in worse health outcomes than physicians. For this reason, physician-led teams are the gold standard in medicine, which is further illustrated by the fact that 45 states do not allow nurse anesthetists to practice independently, and 42 states do not allow optometrists to perform eye laser surgery. If this project moves forward, models of care that are rarely used in the private sector will be formalized across the VA. This will make the VA an outlier in the medical community, erode public trust in the system, and lead to worse health outcomes for our veterans. Now, non-physicians, such as nurse anesthetists, pharmacists, optometrists, physician assistants, are integral members of the care team. But the skills, acumen obtained by physicians throughout their extensive education and training makes them uniquely qualified to oversee and supervise veterans' care. To ensure our veterans receive the care that they have earned, physicians need to remain as leaders of the care team. And if there are universal standards for each profession, then the most vigorous state scope requirements should be implemented. In closing, I want to recognize and thank all those who have served, especially practitioners who brought their skills and their training to the battlefield. As the administration and Congress consider the implementation of this project, it's imperative to remember 4 points. There are important distinctions between care provided in battle and that of routine, planned care provided to veterans that typically have comorbidities due to age and service-connected disabilities. Though I choose to get my care at the VA, there are many veterans that must receive their care at the VA because they have no other option. We must ensure that they receive the best care possible, that of physician-led, team-based care. As leaders of the care team, physician representation on all the VA work groups, not just the physician work groups, should be mandatory. Finally, it is unclear why this project is needed. The VA originally rationalized that they needed this project because of privileging issues with the new EHR. In follow-up meetings, the VA then stated the project was needed to move personnel around the system. These shifting rationales don't make sense and do not align with how good medicine is practiced. As we all work together to ensure that the VA is the best healthcare system it can be, let us truly consider the implications of the federal Supremacy Project, the negative impact it will have on our veterans. Thank you so much for having me here, and I look forward to your questions.
Thank you, Dr. Ehrenfeld. Dr. Barney, you are now recognized for 5 minutes to deliver your opening statement.
Thank you and good morning. My name is Dr. Paul Barney, and I'm here today representing the American Optometric Association. I live and practice in Anchorage, Alaska, where I have served as a center director for the Pacific Cataract and Laser Institute for nearly 25 years. I believe that I bring a valuable perspective to today's discussions, as I'm a practicing doctor of optometry who routinely provides laser and other surgical care to my patients. I did part of my training at an Army hospital and at a VA outpatient clinic. As an adjunct professor at 2 U.S. optometry schools, I'm involved in training the next generation of frontline eye doctors. And as a lecturer, I help keep my colleagues on the cutting edge of patient care. I also understand what it's like to live in a community faced with a shortage of medical doctors and other providers. Roughly 40% of counties or county equivalents in the U.S. have access to a doctor of optometry, but not an ophthalmologist, and that number is expected to grow. America's doctors of optometry are stepping up to fill that gap. Optometry's training and abilities have continued to advance alongside the evolution of technology. Today's rigorous 4-year optometry school curricula focuses exclusively on the study of ocular health and vision care. Laser and surgical education, both didactic and hands-on, is embedded and is a key part of optometric education at both the optometry school level and the postdoctoral level. In fact, contrary to what detractors say, laser and surgical care has been and continues to be taught at each and every school and college of optometry in the country. Doctors of optometry are licensed to practice by their state, and their scope of practice is set by the state's laws and regulations. The trend for the past 50 years has been for states to increase optometric scope of practice. In no case has their scope of practice been reduced. In 10 states, doctors of optometry are authorized to use lasers to treat ocular conditions. In one state, Oklahoma, optometrists have been providing laser eye care for nearly 30 years. State regulators cite that this authority has led to an increase in access to care, particularly in the state's underserved and rural areas. Those state officials also report little or no patient complaints have resulted from this increase in scope of care. Further, malpractice rates for doctors of optometry in states with the authority to provide laser eye care and other contemporary procedures are roughly identical to rates in states without that authority, which highlights the safety and efficacy of this care provided by optometrists. All federal health programs recognize, cover, and pay for doctors of optometry to provide laser and other surgical procedures covered under the state scope of practice. Medicare, Medicaid, the Indian Health Service all cover and pay for the full range of services authorized under an optometrist's state scope of practice. Similarly, all major private payers cover and pay for laser eye care and other surgical procedures included in an optometrist's state scope of practice. And the VA's own community care program recognizes that injections, lasers, and eye surgery can be provided by an optometrist based on the licensure of the provider. Eye and vision care ranks as the third most requested service by veterans. Doctors of optometry provide roughly 3/4 of all eye and vision care in the VA, and with optometrists often being the only eye care provider at many VA facilities, what the department decides to include or exclude from the Optometry National Standards of Practice will have an outsized impact on access and timeliness of care, which will affect patient outcomes and veteran quality of life for years to come. The Veteran Service Organization, AMVETS, has repeatedly urged the VA to ensure that any VA policy ensure veteran access to the full range of care that both ophthalmologists and optometrists are authorized to perform, including lasers and other surgical procedures. AMVETS has shared concerns that if the VA doesn't get it right, its members may not have the same access or choices that other citizens in their states enjoy. At a time when the VA is struggling to meet veteran demand for eye care, it is important that the VA cut through the noise and do what is right for veterans by advancing an optometry NSP that recognizes and ensures veteran access to the full range of care, including laser eye care and other surgical procedures that doctors of optometry are trained, licensed, and fully capable of providing. Thank you.
Thank you, Dr. Barney. Ms. Sintner, you are now recognized for 5 minutes to deliver your opening statement.
Good morning, Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee. Thank you for the invitation to speak today on veterans care. I'm Jan Setner. I am a colonel retired from the United States Air Force Reserves with 26 years of service as a CRNA, a flight nurse, and a senior staff member for the Air Force Surgeon General. As a CRNA who has served as both the anesthesia element team lead over both physician anesthesiologists and CRNAs in the largest in-country medical facility in Afghanistan, and a sole anesthesia provider for the Special Forces Operating Base, I know firsthand that unrivaled anesthesia care is provided by CRNAs without duplicative or unnecessary supervision. I have practiced independently in the most difficult circumstances while serving in the military. CRNAs work without supervision in the Army, Navy, the Air Force, and in countless facilities across the country. If CRNAs are called upon to competently and safely deliver anesthesia in the battlefield without supervision, it's reprehensible to restrict that care to our veterans here at home. As a practicing CRNA, I'm frustrated that my profession is constantly having to defend its value purely for political and self-serving financial reasons, when many peer-reviewed studies have proven CRNA care is safe, effective, and par with other providers. In fact, the VA in its 2016 final rule stated that CRNAs provide high-quality care. Additionally, 90% of veteran households in a survey stated that they support allowing access to CRNAs within the VA. CRNAs also grow weary of hearing that physician anesthesiologists' false narrative that the VA is planning to replace all anesthesiologists with CRNAs, or that CRNA education is inadequate. These are outright falsehoods. The AANA maintains that both anesthesiologists and CRNAs should be available to provide direct patient services, and that VA facilities should be allowed to choose their most suitable anesthesia delivery model. There has been too much political influence on non-physician scope of practice decisions. The AMA and physician groups have a vested financial interest in limiting the scope of practice for other providers. According to their own website, the AMA has spent over $3.5 million to impede the APRNs from practicing to the top of their education and training. I would be remiss if I did not address the Hattiesburg article currently being shared with Congress by our medical colleagues. This study, 1, reviews only nurse practitioners and physician assistants in emergency room settings. 2, does not include or even apply to CRNAs. 3, does not look at CRNA or optometrist practice and has no relevance to the national standards for our profession. Yet, our medical colleagues dishonestly try to extrapolate from this deeply flawed study and draw fallacious conclusions regarding supervision. However, the VA strategic plan released last year highlighted in a study that showing full practice authority for other APRNs has had a very positive effect on wait times for the veterans. Removing barriers to care, including removal of wasteful and financially motivated supervision requirements, is not controversial and is supported by many organizations that do not have a vested or self-serving financial interest in maintaining this antiquated status quo. These include 2 past administrations, the Bipartisan Policy Center, the AARP, the National Rural Association, the Brookings Institute, and the Americans for Prosperity, among others. The men and women who serve selflessly, or the men and women who have served our nation, deserve timely and quality care. All scientific evidence and multiple independent groups have concluded that that is CRNA care. In conclusion, I would like to commend Chairwoman Miller Meeks' Iowa VA facilities for setting the standard of what a great collaborative full practice CRNA physician anesthesiologist practice looks like. It's noteworthy that Iowa was the first state in the nation to opt out of physician supervision for anesthesia care. In both Iowa City and Des Moines facilities, all CRNAs practice independently to the full extent of their education and training, thus enabling the physician anesthesiologist to do their own cases. This decreases wait times, increases access to quality care, and improves patient safety and satisfaction. All providers do high acuity, complex cases, and all take call independent of each other. Both facilities consistently rank among the most highly rated of VA facilities, and they invite you to come and shadow them at any time you wish to see this in progress. Thank you very much for your time. I appreciate it.
Thank you, Ms. Sittner. Dr. McLeod, you are now recognized for 5 minutes to deliver your opening statement.
Good morning, Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee. My name is Dr. Stephen McLeod. I'm the Chief Executive Officer of the American Academy of Ophthalmology. I've served in this role since 2022. Prior to that, I was chair of the Department of Ophthalmology at the University of California, San Francisco, 17 years, and served as a staff ophthalmologist at the San Francisco VA Medical Center. I'm here today on behalf of the American Academy of Ophthalmology to voice our deep concern that veterans will be put at risk if the VA adopts national standards that allow optometrists to perform surgery. First, let me say that we strongly believe that optometrists are vital members of the eye care team. During my tenure at UCSF, I actively developed these collaborative team-based models and continue to support them as a national model of care. However, our efforts recognize the different training, skill, and expertise of each team member. I must emphasize that as medical doctors with extensive surgical training, indeed many thousands of hours devoted specifically to eye surgery, only ophthalmologists possess the expertise and the experience required to perform eye surgery and to address the potential complications that might arise. The VA must exercise extraordinary caution when it comes to setting standards for allowing eye surgery. Eye tissue is extremely delicate and unforgiving. The surgery is considered amongst the most technically challenging, and damage is simply impossible in cases to repair. Currently, the vast majority of states, 41, do not allow optometrists to perform laser surgery. There are a handful of states representing a small fraction of the US population that allow other surgical procedures, but even within these states, optometrists' scopes of practice vary considerably. Optometrists are restricted from performing surgery in most states of the VA system for a reason. Optometrists are not trained to safely perform surgical procedures. Optometry training primarily focuses on the correction of refractive error, glasses and contact lenses, and on primary eye care. While the curriculum includes some didactic education on surgical topics, meaningful, hands-on surgical training is not included. In states where optometrists have been granted limited surgical privileges, training often consists of a condensed 32-hour certification course conducted at a hotel venue, not a clinical facility. There is no hands-on patient surgical experience, which is obviously a crucial component for competent, safe, and successful eye surgery. An optometrist trained under these circumstances may, in fact, attempt their first unsupervised laser cases having never used the equipment on a human eye. There's also evidence that suggests that patients who receive surgical procedures from optometrists experience poorer outcomes. A 2016 study published in the Journal of the American Medical Association, Ophthalmology, found that there was nearly triple the likelihood of repeat laser treatment in the same eye when the surgery was performed by optometrists compared to the same surgery done by ophthalmologists. Now, the stated goal of the VA Supremacy Initiative is to develop national standards that ensure that our veterans receive the same high-quality care regardless of where they enter the system. Extending surgical privileges to a subset of providers with vastly inferior training based only on location violates both fundamental principles, quality and consistency regardless of entry point. To compound this further, it's possible that the VA would grant optometrists licensed in one state the privilege to perform surgery nationwide, potentially overriding state-specific laws and expanding risk to patients across the VA. For example, an optometrist licensed in Oklahoma could be allowed to perform laser surgery in Iowa, even though Iowa, like 40 other states, for safety reasons, prohibits optometrists from performing laser surgery. As I conclude, I'll share my own state's experience with the issue. Nearly a year ago, California Governor Newsom vetoed Assembly Bill 2236, which would have allowed optometrists to perform surgical procedures. In his message, the governor stated, and I quote, "I'm not convinced that the education and training required is sufficient to prepare optometrists to perform the surgical procedures identified. This bill would allow optometrists to perform advanced surgical procedures with less than 1 year of training. We cannot allow our nation's veterans to receive complex surgical procedures from those who simply don't have the training and expertise to perform them. All of our nation's veterans need and deserve the highest level of care, and that means regardless of site, only surgeons should perform surgeries." Thank you again for the invitation today. I look forward to your questions.
Thank you, Dr. McLeod. Dr. Harder, you're now recognized for 5 minutes to deliver your opening statement.
Good morning. Thank you, Chairwoman Miller-Meeks and Ranking Member Brownlee. I'm here on behalf of the 56,000 members of the American Society of Anesthesiologists. We strongly believe that VA's proposed move to a nurse-only model of anesthesia care is a solution in search of a problem, a solution that could risk veterans' lives, especially toxic exposed veterans. There is no shortage of anesthesiologists in VA. As of yesterday, there were only 22 position vacancies for anesthesiologists in VA out of 1,000 total positions. The average vacancy rate for anesthesiologists this year is just 2%, well below the national average. VA has the right anesthesia policy in place right now. It's consistent with what every top-rated civilian hospital provides, what 45 states require, and what VA reaffirmed in 2016 after years of thorough review. VA is going to tell you that there is no evidence from impartial, independent studies to indicate that full practice authority for CRNAs leads to either improved or adverse outcomes. A lack of evidence is not the same as a demonstration of safety. VA has not met the burden of proof to show evidence that CRNA-only care is safe. Congressional action is required. VA addressed this burden of proof question in 2014 when VA's own researchers conducted the query study that specifically questioned whether more complex surgeries can be safely managed by CRNAs providing anesthesia alone. Without meeting this burden of proof, VA is risking the health and lives of veterans with its proposed policy. VA has an ethical obligation to meet its burden of proof that it will not harm veterans before putting in place a new policy that not one top-rated civilian hospital allows. This issue cannot be fully addressed without consideration of PACT Act veterans. It makes no sense for VA to spend billions of dollars to treat PACT Act veterans with respiratory disease and then fail to provide them with the same level of anesthesia care delivered at all leading civilian hospitals. This committee and its members were instrumental in the passage of the PACT Act. Toxic exposed PACT Act veterans have acquired lung disease that typically increases the risk of anesthesia. These veterans have the right to ask this question. Since the passage of the PACT Act, Has VA conducted an independent study of the increased risks of anesthesia on toxic exposed veterans? Anesthesiologists and CRNAs are not interchangeable. Using basic common sense, there are 100 anesthesiologists members of ASA who were CRNAs before they made the decision to go to medical school for 4 years and then 4 years of residency. Why would they spend years of their life doing that if there was nothing more for them to learn? They decide to pursue those additional years of rigorous medical education and training to prepare them to make the split-second decisions that can mean the difference between life and death. I have spent most of my career teaching and training medical students and residents in the medical specialty of anesthesiology. Although nurse anesthetists are truly outstanding advanced practice nurses, they are not anesthesiologists. CRNAs are educated and trained to work with anesthesiologists as a member of a team, not to practice medicine. In fact, with one exception, every CRNA training program is located in a state that requires a CRNA to work with a physician in the delivery of anesthesia care. Any claim that CRNAs are trained to practice without physician supervision is not accurate. Despite various nursing organizations suggesting the CRNA-only model is commonplace, the CRNA-only model is rare. Only 5 states permit the CRNA-only model of care, and even in those states it is used infrequently. All other states require physician involvement with CRNAs, whether it be supervision, direction, collaboration, or other state-specific terms. Whatever the terminology, CRNAs in 45 states must work with a physician. Finally, I was pleased to read the American Legion's statement and respect them for seeking veterans' thoughts about this important issue. They found that 91% of respondents support the physician-delivered and physician-led anesthesia care team model. Nearly 3/4 believe that dismantling or altering this model will subject veterans to a lower standard of care than civilians receive. Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee, thank you for your time and attention to this issue, which is critical to our veterans. I welcome your questions.
Thank you, Mr. Harder. We'll now proceed to questioning. As has been my custom, I will delay my question to the end, but before I go to the first questioner, the first member, I just want to say to all of our witnesses, for those who have served, thank you for your service, and to those who serve our veterans at a VA facility, thank you for serving our veterans. With that, the chair now recognizes Representative Bergman.
I'm recognized?
Yes, sir. Oh,
Okay. Thank you, Madam Chairwoman. Members of the military don't get too excited about a lot of things, but what we do get excited about negatively is we use the term in the Pentagon, protecting rice bowls. And you all know what that means. You got your little rice bowl of appropriations and all those things that you do, and that's human nature. You all aren't alone in that. When I started as a Marine, I started in rice paddies. So if you get the drift, in the late 60s, early 70s, so I really wasn't concerned about rice bowls, and I would suggest to you our veterans of today who served in places like Iraq and Afghanistan they're not interested in rice bowls. They're interested in what they observed in the desert and experienced in the mountains and all of that in different ways. So one of the challenges we have as a committee is to separate what is a rice bowl that's being protected for the right reasons or not. And I thank both sides of the aisle here on this subcommittee, especially to make sure that we're doing the right thing for the right reason for the veterans in all cases, regardless of which rice bowl it may fall in. So, having said that, Dr. Barney, am I correct to understand that under Medicare, Medicaid, and Indian Health Service all cover and pay for the full range of services authorized under an optometrist state scope of practice, and in addition, all major private payers cover and pay for those services, including laser eye care and other contemporary procedures included in an optometrist's state scope of practice?
Yes, that's correct.
Okay, with all of that being true, would it be correct to say that VA is currently an outlier among all private payers and other federal programs? And could you speak to the impact that this could have on our veterans' access to, in this particular case, eye care?
Yes, I think that would be a correct statement, especially if you consider the VA's community care program. The community care program does pay for laser procedures provided by an optometrist outside of the VA facility itself. If there is a restrictive optometry NSP, I would foresee a scenario where a veteran would not be able to get access to laser eye care by an optometrist within the facility, but could go outside the facility and receive that care. Okay. To me, that seems like not a very wise use of VA funds and resources.
Thank you. Ms. Setner, can you discuss the role that nurse anesthetists play in rural and remote areas, in this case, like Michigan's 1st District, which is not only rural, it's really, really remote?
CRNAs cover almost 100% of the rural health medicine in most of the states. Several facilities are now closing down because of an inability for access to have these care models delivered. So I could say that with certainty that CRNAs practice independently in these settings.
Okay, thank you. And finally, Dr. Harder, can you point to any evidence that shows VA is trying to replace anesthesiologists, as you say the ASA has claimed?
The move to remove physician supervision simply would have that opportunity arise, that there could be VA facilities that might, for various reasons, opt to not have physician anesthesiologists if they're no longer required to be present.
So, okay, we think that might be an outcome at this point. Nothing has occurred to this point that point to the fact of a lower standard of care.
Well, we would be, I think, speculating as to what might happen one way or the other.
Well, that's okay, because we have to, in all cases, now, I see I got about 20 seconds left, we need to make sure, as best we can, as members of Congress, that what is being done at all bureaucratic levels within the federal government, in this case, especially Veterans Administration, that it's being done for the right reasons with outcomes for veterans in mind, not outcomes for the bureaucracy. And with that, I yield back.
Thank you, Representative. The chair wants to issue a sincere apology to Ranking Member Brownlee for going out of order, and I now recognize Ranking Member Brownlee for any questions she may have.
No worries, Madam Chair, not at all. So my first question really is to the physician groups that are here testifying, because I just want to get some clarity in our roundtable meeting that Dr. Miller-Meeks and I had back in April. There was testimony there that said that the VA was not really being transparent and or responsive. So I just want to get some clarification. The VA says that they're reaching out, so I want to get some clarification from you where you stand on that issue. So, Dr. Ehrenfeld?
Thank you for the question, really appreciate it. The VA has not involved the AMA in the development, implementation, or decision-making around the Supremacy Project since we became aware of this in 2021. We have made it clear to the VA that we would love to be involved. We would love transparency. I think that's how we separate out whether this is a rice ball or rice patty.
Dr. McLeod.
So we've been somewhat frustrated by a difficulty in really being able to get clarity, and we do think that it's moving in the right direction. But you know, from our perspective, an entire process is looking at delivering eye care within the VA, where the eye care is going to be delivered by optometrists and by ophthalmologists. That does not bring both groups into the room at the same time to come up with the most rational way of dealing with the patient's needs is not in the best interest of the patients, and that has not happened.
Thank you, and Dr. Harder.
Much the same. We have requested to have opportunity to have discussions about this and then specific to nurse anesthesia practice under the proposed national standards of practice, and to this point have not had the opportunity to provide that.
Great. And Dr. Barney, do you have anything to say with respect to my question?
They've been communicative with us. We've not been involved with all the details, but they've been communicative with us. So, yeah.
Thank you. Ms. Stetner?
Has had an opportunity to participate at various levels.
Apologize on your name.
No worries.
Get it right the next time, I promise. So, you know, I've been on this committee for 10 years, and I am not a doctor, so let me be clear about that. But I will say it has been the VA who convinced me early on that a team-based model is the best model, and the gold standard. I think someone mentioned the gold standard in terms of healthcare. And so, you know, the VA has also asserted in its testimony and during recent staff briefings that its National Standards of Practice initiative will not eliminate nor change the department's current team-based model of care. So I don't know if everyone is confused. I'm a little confused because I hear testimony that this is not the direction the VA is going in. The VA is saying they're going to hold on to the model of care. So I guess I want to ask you, what is your definition, or what does a physician, what does a team-based model of care mean? And if we can be brief in the answers, because I think most will say it's physician-led, some may not. So I'll start again with Dr. Ehrenfeld.
Thanks for the question. It's really important. The AMA strongly supports physician-led, team-based care. Nobody should be practicing in a silo, and that means nobody should be practicing by themselves.
Dr. Barney.
Yes, we support physician-led care, but keep in mind that optometrists are physicians.
Thank you. And Ms. Setner.
So team-based care in the Air Force, if you look at our statutes, it actually says that the team-based model is actually the best, but it also states that the team lead can also be a CRNA as well as an anesthesiologist. It's the experience and level that you're looking at. And as explained when I was deployed, we worked as a team. Anesthesia is not a one-man sport. It takes a whole team to conduct anesthesia in a facility. You need the surgeon, you need your whole team to make it happen. So in essence, it is a team sport, and either person can be team lead.
Dr. McLeod.
In our space, some ambiguity has been lent to the term physician, and so we'll be specific. In our space, we believe that it should be an ophthalmologist-led team.
And Dr. Harder.
Not surprisingly, we also feel that it should be physician-led care. I do want to say, to make a distinction, we are not advocating that it must be anesthesiologist-led care. There are certainly settings, both in the private sector as well as within the VA, where currently the physician providing that supervision is the operating surgeon. So any thoughts that this will somehow create better access, reduce costs, et cetera, it's already, they're able to do that model currently without removing any need for physician oversight of the nurse anesthetist.
Thank you. My time is up, but I do have more questions. I'm hoping that we may have another opportunity, Madam Chair.
Thank you, Ranking Member Brownlee. The chair now recognizes Dr. Murphy for his questions.
Thank you, Madam Chair, and thank each of my members. And I want to thank all of you guys for coming out and dedicating your lives to the practice of taking care of people. I don't see any greater cause personally and professionally. I've done one for 35 years, and I much prefer the title of doctor rather than congressman. Don't take that any wrong way, but sorry, folks. That said, being a doctor is in my DNA, and these scope of practice issues are always coming up. It's like playing whack-a-mole sometimes, and I call it scope creep. And The term is, I want to practice to the highest level of my license. And I absolutely understand, but I think it's imperative that folks understand where that phrase comes from and what it means. Who gets to determine what your license is your peers. It's not someone who does a procedure by training and has done it 10,000 times. It's something that your peers say, hey, I think you should be able to do this. And so when you say, I want to practice to the level of my license, it's really a misnomer as to what you're saying. It's really saying, I want to practice to the level of what my friends and my colleagues say I can practice. It's not practicing to the level of what people who are actually done specific training in that field say you can do. That said, there is overlap. There is obviously overlap. I'm a urologist, gynecologist. There's plenty of overlap. There's plenty of overlap between differing fields. But when it comes to surgery, and it comes to keeping somebody alive under anesthesia, the overlap really hits a wall. I worked with nurse anesthetists, have for 35 years, have wonderful relationships with them, absolutely. But when the proverbial hits the fan, I want an anesthesiologist in the room. And I have had many, many, many circumstances because I'm a cancer surgeon, or I've done a lot of cancer surgeries, and when someone's life's at the stake, I want the person with the highest level of training to be there. I wear glasses, and thank God for my optometrist, or I'd be fumbling more than I actually fumble around anyway. That said, I personally don't believe a weekend course, a couple-week course. It's fine when you know a narrow band of knowledge, and that's fantastic. You may know that, but as we all know, there are complications that step outside here, there are complications that step out here, and unless you know the depth and the breadth of what is in that field of pathology, I don't fully feel you know the disease process that you're working with. The VA, we're talking with anesthesia, is not having a problem getting anesthesiologists right now. Optometrists and ophthalmologists may be a little bit different things. And I understand, I absolutely understand that you are all passionate for wanting to take care of our veterans. Absolutely. There's nobody in this room that is not passionate for wanting to take care of our veterans. But in my opinion, in my medical opinion, there is a team concept, and there has to be one quarterback for a team. If not, it is absolute anarchy. And yes, there are some gray areas and there are some definite partnerships between CRNAs and anesthesiologists, without a doubt. There are excellent partnerships between optometrists and ophthalmologists, absolutely. Some see post-op patients and everything. But when we use the scope creep and the term of license or practicing to the highest ability of my license, it's a little bit, and I hate to say, this may come across the sound way, it's a little bit disingenuous because where you got that license from is really not where the expertise lies. So I don't have any specific questions because I think you guys know where I stand. I want everybody under the same tent because the same tent is that which cares for our veterans. And lessening, in my opinion, the quality of care because of a perceived access issue really is not what our veterans deserve. They're not what our veterans deserve. I do believe there can be some common ground to help our VA achieve care for all of our veterans, but I don't believe in decreasing the quality of care and the expertise of care. With that, Mr. Chairman, I'll yield back.
Thank you, Dr. Murphy. The chair now recognizes Mr. Van Orden for 5 minutes.
Thank you, Madam Chair. Dr. Setner, I understand that you served in Afghanistan. That's correct. What years was that? Or were those?
2008,
Okay.
and I'm not a doctor.
Okay, sorry, ma'am.
You can call me Colonel if
I
you
think
want.
that's what this is all about, isn't it? I will, Colonel. I tell you what, I'm going to praise you publicly for the work that you did in secret. Because if you're in Afghanistan in 2008, there's a 100% chance that you are responsible for saving the lives of some of my Navy SEAL brothers. I want to thank you for that.
Thank you.
Actions speak louder than words. I'm from the state of Wisconsin, and behind that door, my staff has brought you some cheddar cheese from the state of Wisconsin.
Yay.
To quote the president, that's not a joke. Dr. Aaron Feld, do you consider yourself a subject matter expert in the medical field?
Yes, sir.
Good. Do you consider the American Medical Association the gold standard for medical expertise and advice?
Very proud of what the AMA is able to represent in serving the needs of our patients and physicians.
That's not the question I asked you. Do you consider the AMA the gold standard for medical expertise and advice?
I'm not sure I can answer that, sir.
Okay. Is smoking bad for you?
Yes, sir.
Are using Class 1 narcotics for recreational use bad for you?
Yes, sir.
If you put an unprotected hand in fire, will it be burnt?
Yes, sir.
Can a biological male become a biological female?
I'm not sure I understand the question, sir.
That's the problem, isn't it, doctor? Can a biological male become a biological female?
I'm not sure where you're going with that, sir.
And that's even more troubling. The issue is this. You know the answer to that question. You're just not going to say it because you're playing politics with medicine. So is your organization. And that's not just dangerous, it's terrifying. So from my opinion, you are not a subject matter expert in the medical field, or you're exercising administrative cowardice because you know the answer to that question, Commander. Dr. Hartner.
Harder.
What is it again?
Harder.
Oh, sorry about that. Yeah, thanks. You submitted a 17-page biography and CV. You submitted less than a single page of written testimony, and yet you spoke for 5 minutes. That's correct. That's all I got, man.
Our written testimony was several pages, so I can't speak to the disconnect.
Oh, when did you give us the updated one?
I believe it was at the end of last week. I don't know exactly. The 15th.
Okay. Well, there went that ship, didn't it? My concern is this, sir. Can you positively demonstrate a dearth of care for veterans due to a lack of anesthesiologists in the VA?
With respect to wait times, et cetera?
Yeah.
No, we're not aware of that being certainly global. I can't speak to every VA facility in the country, but
Okay.
But again, our knowledge is that there are very few vacancies for anesthesiologists within the VA system, which would suggest that staffing is appropriate throughout the system.
Okay, so when my colleague General Bergman was asking you about these things, you said you're not going to speculate on this and that, correct?
Correct.
So if you can't positively demonstrate to me that there is a dearth of anesthesiologists or care, high quality, timely care for our veterans, if you can't demonstrate that to me concretely, then you are speculating. It's in the dictionary, dude. So here's the thing. If you can't demonstrate that our veterans are getting high quality care in a timely manner, what you're saying is meaningless. So I would like to see from you on paper a chart that shows me that our veterans are not getting high quality, timely care, because that's the only reason that we're all here. It has nothing to do with your 17-page biography and CV, sir.
To be clear,
It's not about status. It's not about a badge. It's about high quality, timely care to our veterans. And with that, I yield back.
can I?
Thank you,
If the chair so recommends.
Mr. Van Orden. You may respond, Dr. Harder.
Just to be clear, our assertion is the current state is that there's not a shortage of anesthesia providers. And so therefore, making significant changes to the scope of practice of the nurse anesthetist, there's no compelling reason to do that. Is the question to show that there is currently a shortage of anesthesia providers, or to show that there is not?
Thank you.
Thank
The
you.
chair now recognizes Representative Kiggins for 5 minutes.
Thank you very much, Madam Chair. I proudly represent Virginia's 2nd Congressional District, home to a large veteran population and active duty military as well. I served in the Navy myself, too, for 10 years. I'm also a board-certified adult geriatric primary care nurse practitioner and have had the privilege of taking care of some of our greatest generation in many different care settings with many different care teams. So I consider myself possibly a subject matter expert in this topic today. I want to start with the 3 things that I think that we can all agree with. I think that we can all agree that we have a healthcare provider shortage. There's not enough of us, right, to give the care that we need, especially in the VA setting. I think that we can all agree that no one practices in a silo. I know you guys talked about that, and Ms. Setner, you talked about it being a team sport, and I certainly think that healthcare is a team sport. No matter where you are, even if you're the only provider in a rural setting, there's always somebody you can call. You're gonna text somebody or get an answer to your question if you don't have that answer. And the third thing I think that we can agree on is that VA healthcare has much room for improvement. I've been in Congress for 9 months and have sat on this committee proudly and have listened time after time about veterans that come and different care organizations that come and tell me that VA healthcare is inadequate, 100%. We've got to do better for our veterans in a lot of different areas. I'll tell you what is harmful for veterans. You know, a couple of you spoke about harming veterans. What harms veterans is when we can't give them the health care that they deserve. I'll get off my chest just ever so briefly with Dr. Ehrenfeld about some of your comments about non-physician providers and advanced practice nurses. They were offensive to me personally, as someone who has worked with some of the greatest geriatricians in the world to take care of very vulnerable people. To even say that there's worse health outcomes for nurse practitioners, we practice differently. We just do. I mean, we're educators, we're nurses. We don't want to be doctors. That's where I think a lot of physicians really get confused. We don't want to do open heart surgeries. We don't want to take your place. We want to partner with you. And that's where we need that recognition. And we fight day in and day out. You talk about that we have higher expenses, that because we order more tests, perhaps we're being more thorough. Perhaps, and you want to talk about expenses, we are a cheap form of healthcare. Advanced practice nurses, we have to fight for the pay that we get. We aren't compensated, in my opinion, as much as we need to be. So be careful with the rhetoric you use in the companies that use it in. And you talk about, the VA and why this committee and why Congress is now weighing in on this issue, this federal issue. Well, that's our job, right? In Congress, we provide oversight, especially for federal health care, which is the VA. I know there's state standards. I sat in the state Senate for 3 years where we argued about autonomous practice for nurse practitioners. And during COVID, it was 5 years. We had to practice for 5 years before we could even apply for to practice independently. And during COVID, we switched it to 2. So after 2 years as a nurse practitioner, then with 2 years of experience, I could practice independently during one of the most challenging healthcare times in our country, where we invited sick people to come visit us. And we took care of them every day, and we said, come see us if you don't feel good. We'll take care of you. With 2 years of experience. And then after COVID, they wanted to switch it back to 5. How can you even why is it different at different times? And I know, Ms. Setner, you talked about on the battlefield when nurse anesthetists could perform the same duties. Why is it different? Either we're going to do it one way or we're going to do it another way. But I wanted to, again, talk about also kind of the eyes and ears argument. I know we have the optometrist and ophthalmologist. My dad is a Vietnam veteran. He was a Green Beret, and he only uses VA healthcare for 2 things. That's for glasses and for hearing aids. And so many of my patients, the same. Glasses and hearing aids are expensive. So if we don't expand these care teams, I've been a supporter of even expanding it to pharmacists, simple things. Within scope, I think that there's a discussion to be had about what's your scope of practice, but we've got to acknowledge that we need to expand our care teams, because we're struggling. Wait times, access to care, patient satisfaction, we are not there. So if we don't look at some of the obvious answers that are in this room, then we're failing our veterans. And I want to yield my last few seconds to Ms. Setner. If you could please, in your own view, how has the expansion of full practice authority for APRNs affected availability and quality of care at the VA?
Thank you for the question. One thing I'd like to clarify that Dr. Murphy kept referring to was licensure. He never referred to our education and training. The education and training of CRNAs is exemplary. We are educated and trained to practice at the highest level. We are airway experts. To take care of the PAC patients, we can do that easily. As far as expansion of care, as I mentioned to Dr. Miller Meeks' facility in Iowa, they have the best team care model. They work independently of each other, and they take care of very sick patients. They have high acuity, and they're very complex cases, and they do it seamlessly. And they have invited members of Congress to come and shadow them so that they can see the work in progress.
Thank you. My time's expired. I'll yield back.
Thank you, Representative Kiggins, and maybe we can silence some phones, although I like the song, but the chair now recognizes Representative Scott for 5 minutes.
Get the mic on. Thank you very much. First, I want to thank Chairwoman Miller Meeks and Ranking Member Brownlee for allowing me to participate in this incredibly important hearing and for your support for our fantastic veterans. And let me just start by saying that for over a decade, and spanning 3 different administrations, I have called for the VA to reject any proposal that removes the medical expertise of physicians during intricate surgical procedures with our veterans. And I was very pleased that after years of extensive review and study, and at the urging of myself and other members of Congress, medical organizations, veterans, and the veterans' family members, that then VA Secretary McDonnell put our veterans first. But unfortunately, this current administration has put forth this proposal yet again that would replace the current method of anesthesia administration, meaning that complex surgeries could be performed without the presence of trained anesthesiologists. And ladies and gentlemen, we're talking about these surgeries being applied to our precious veterans of all groups. It is our veterans that have battlefield wounds, that have intricate problems. And if there's anybody that needs to have the best and most reliable anesthesiology care, it's our precious veterans who volunteer to put their lives on the line, on the battlefield for us. They need physicians that are trained with the latest information, the best talents possible. Now, I have great respect for our nurses. My daughter is a nurse at Grady Hospital in Atlanta, Georgia. I love nurses, but they are not qualified to give the level of expertise when it comes to anesthesiology. That is the most important part of having surgery, putting our veterans to sleep so that surgery can be performed with the best of care, but very importantly, waking them up after a successful surgery. There is no more important thing. Don't our veterans deserve the best? All of our American citizens do. But it would be a mockery and a hypocrisy if we do not perform this for our veterans. Each of you on the panel, if we have to have surgery, would not we want to make sure we have a trained physician conducting that basic talent that they have? And so, if I may, I'd like to ask a question of Dr. Harder. If the administration, Dr. Harder, allows this proposal, the Atlanta VA in my home state will move to a nurse-only care model, while other world-class hospitals in Georgia continue to use the anesthesia team model. Why, Dr. Harder, should veterans in Georgia or anywhere in our nation have a lower quality of care and safety than any other member of our nation or citizen of our state? Dr. Harder.
Thank you, Mr. Scott. Clearly, we feel that there shouldn't be a different standard within the VA system than for what's in the civilian setting for 45 states in the nation, and is used even in the other 5 states. It's a very frequently used model to still have the anesthesiologist or physician-led anesthesia care team. So we feel that the standard should be at least as high within the VA system as it is in the civilian setting.
Well, thank you very much for that response. And is my time? All right. Thank you all very much.
Thank you, Representative Scott. The chair now recognizes herself for 5 minutes. Again, thank you all for your testimony, for being here. For those who've served, thank you for your service, and for those who care for our veterans, thank you also very much. And Ms. Settner, thank you for your comments about Iowa and Iowa VA. Physicians it is a physician-led team. The surgeon who is a physician is in fact in care in the operating room for all care. And as a practicing physician who worked with CRNAs and have deep respect for them, I was in fact the supervising physician during those care and those procedures. I also would like to say that in my time as a faculty member at the University of Iowa, we had optometrists that were on our faculty. In my private practice in Ottumwa, Iowa, we had a local optometrist join us who had done an internship at the VA in St. Louis, and that person was a full partner in our practice, not an employee and not subservient to me. However, I do feel that there is a difference in care, and the concern that I have is that you'll see behind me a poster, and Dr. Barney, can you tell me what that is? Maybe we can raise it up.
It's a multifocal IOL. Looks like we might have some capsular opacification. From this distance, it's hard to tell, but it looks like a multifocal IOL.
Yeah. It is a multifocal IOL that underwent a YAG capsulotomy by an optometrist who was trained by another optometrist. The veteran was sent out of state to go to a state where it is under the state's licensure laws that optometrists can do YAG laser capsulotomies. And I will fully admit that I have pitted an intraocular lens before. I am not pure, but this is a multifocal intraocular lens that was severely pitted, and it cost $20,000 to have this removed from that veteran in another state when they went back to their practicing state after they had been sent out of state by an optometrist. That's why this is a concern to me. So, Dr. McLeod, in your written testimony, you referenced the team approach to eye care helps ensure patients receive the most appropriate treatment in a timely manner. Can you elaborate on the benefits of this team approach that it has for patients as well as for the healthcare system itself?
Absolutely. As we look at the healthcare systems, we recognize that there's a full range of care that's required, whether you're out in the community or in the VA. It's been referenced that that access for patient care is really important. When we look at the volume of cases coming in, having a system in place that you can adequately deal with well eye care, adequately deal with the need for glasses and contact lenses, meet those basic needs is really important. That's actually a huge volume. But beyond that, we have glaucoma, we have macular degeneration, we have diabetic retinopathy. There's a whole series of things that need to be taken care of, but different people need to do different things. And making sure that there is an adequate optometric supply in order to deal with the primary eye care, the glasses, contact lenses, actually is one of the things that will really help getting patients through. But once patients get into a disease state, having physicians that have the expertise to manage those diseases appropriately, to then get them to surgical care when necessary, to do that surgical care working with the optometric group, allows for a system of care that is able to manage a given patient and a population of patients through the system in a timely manner with high quality, safe care. We have to work together for this.
In its written statement, the American Optometric Association states that state regulators have made it clear that little or no patient complaints have resulted from the expansion of state optometric scope of practice laws. And let me also say that the physician who removed that intraocular lens and brought this case to me, there was no complaint reported nor any lawsuit filed. So what have you heard from ophthalmologists or other providers that are practicing in these states?
Okay, so the first thing to address is sort of the misconception that it is a norm out in the community for optometrists to be doing laser surgery. It is not the norm. There are approximately 33,000 optometrists in the country. If you look at the total percentage that are doing the YAG laser capsulotomy that you reference, it's 0.5% of the total. If you look at laser cases, it's 0.1% of the total. So bringing optometric surgery into the VA with any degree of scale is actually a far outlier from what happens in the community. So then when you look at the relatively small percentage that we do see, unfortunately, what we see is an overrepresentation of outcomes that we would be concerned about. Now, what you'll hear is we don't have a lot of data for poor outcomes. And much of that is that we actually, as systems of care, do not have good systems for capturing and reporting poor outcomes unless it is volunteered by practitioners. And the last point that I'll make is that malpractice rates are not a good way of looking at whether care is good or bad. People don't typically get sued because they've got a bad outcome. They get sued because they have a poor relationship with an unhappy patient. You can smooth over a lot of poor outcomes with your relationship, and that's not what we want for our veterans or for the American population.
Thank you very much. I'm sure we would all have more questions that we would want to ask, but on behalf of the committee, I thank you all for your thoughtful testimony and for joining us today. You are now excused, and we'll wait for a moment as the second panel comes to the witness table. Welcome, everyone, and thank you for your participation today. Joining us today from the Department of Veterans Affairs are Dr. Erica Scavella, Assistant Undersecretary for Health and Clinical Services and Chief Medical Officer, Dr. Christopher Saslow, Assistant Undersecretary for Health for Patient Care Services and Chief Nursing Officer, and Mr. Ethan Kellett, Executive Director, Office of Regulations, Appeals, and Policies. Dr. Scavella, you are now recognized for 5 minutes to deliver your opening statement.
Good morning, Chairwoman Miller Meeks, Ranking Member Brownlee, and distinguished members of the subcommittee. Thank you for the opportunity today to discuss VHA's position regarding national standards of practice. Accompanying me today are Dr. Christopher Saslow and Mr. Ethan Kellett. VA is developing national standards of practice for 51 occupations to ensure safe, high-quality care for our nation's veterans and to ensure that VA healthcare professionals meet the needs of veterans wherever they are located. National standards are designed to increase veterans' access to healthcare and improve health outcomes. VA is committed to ensuring that stakeholders are engaged in the process to develop national standards of practice in each and every healthcare occupation. VA has not yet finalized national standards of practice for any of the occupations. The national standards of practice will be designed through extensive internal and external expert consultation. To further engage with key stakeholders, VA has been hosting listening sessions in August and September 2023 for professional associations, veteran service organizations, the clinical community, the public, and members of Congress to provide to VA their research, input, comments on variances between state licenses and scopes of practices, as well as their recommendations on what should be included in VA's national standards of practice. VA will consider all feedback received in these listening sessions when drafting the national standard of practice for each discipline. When the draft national standard is ready, it will be published in the Federal Register for public comment. Further, VA will send to every state board for that profession a letter with information on the impact of the proposed national standard of practice on the specific state, with an opportunity for the state to respond. The development of national standards of practice will not undo the longstanding team-based model of care already established within VA that ensures competent, safe, and appropriate care for veterans. VA encourages a team-based approach to patient care. National standards of practice will support defined roles within the team regardless of state. National standards of practice are intended to strengthen the team-based care and thereby generate the best possible access and outcomes for veterans. Patients are familiar with the concept of having a team of caregivers, including nurses, physical and respiratory therapists, and others. The anesthesia care team can be considered a more specialized model of that team. CRNAs provide anesthesia care for surgery, trauma, procedures in non-surgical and critical care settings, and chronic pain management as part of the patient care team. VA has a proven team-based model of care involving both anesthesiologists and CRNAs, as well as various additional types of providers, including trainees from both medical and nursing training programs, who come to VA for its longstanding tradition of training excellence. The team concept relies on the understanding that no one provider is alone and unsupported. Team-based care relies on the knowledge and discretion of the facility anesthesia leadership, who determine the team composition based on multiple factors. Major procedures performed at complex VA facilities, such as cardiothoracic surgery, require the expertise of both subspecialty-trained anesthesiologists as well as experienced CRNAs with additional training or experience in cardiac anesthetic management. More commonly performed procedures, such as screening colonoscopies, are completed much more widely throughout our system. These procedures can require careful preoperative evaluation, and certain patients may safely receive their anesthesia with a CRNA providing the principal care with appropriate collegial support if needed. In regard to the CRNA National Standard of Practice, VA will only include independent practice if VA determines it is appropriate, safe, and the best interest of veterans. VA anesthesiologists and CRNAs will continue to work as a team and independently, where appropriate, to provide vital anesthesia care to veterans throughout the United States. The Temple University School of Law was contracted to conduct an independent third-party comprehensive review of each state's licensure requirements for CRNA and analyze the differences in CRNA practice across the country. This data is now being used to develop the CRNA National Standard of Practice by a team of expert CRNAs and other advanced practice nurses and physicians. We intend to release this data in the coming weeks. In regard to the Optometry National Standard of Practice, VA is currently evaluating whether the National Standard of Practice will authorize optometrists in the 10 states that allow eye surgery to practice and operate within the full scope of their license. VA does not intend to allow VA optometrists who hold a license in any other state to perform laser eye surgery. We received great feedback from the listening session held on August 31st. VA is using the information presented to determine what should be included in the proposed national standard. We appreciate the input of the committee, lawmakers, and all stakeholders on this important issue. We are committed to honoring our nation's veterans by ensuring safe environment to provide exceptional health care. To close, our next listening session is this Thursday on the 21st, and will allow stakeholders invested in VA anesthesia care the opportunity to provide research, input, and comments on the variance between CRNA, state licenses, and also to provide recommendations on what they believe should be included in VA's proposed CRNA National Standard of Practice. VA will consider all feedback received at the listening session when drafting the National Standard of Practice. Chairwoman Miller Meeks and Ranking Member Brownlee, we appreciate your continued support and look forward to answering your questions.
Thank you, Dr. Scavella. The chair now recognizes, is Mr. Saslow talking? Excuse me. I'm going to defer my questions to the end, so the chair now recognizes Ranking Member Brownlee for any questions she may have.
Thank you, Madam Chair. I just wanted to say I wanted to have a follow-up question on the first panel and was unable to, but I just want to make it clear that my concern is that VA have the same kind of standard that hospitals outside of the VA have. And I know with physician-led teams, it is, even in rural hospitals, it was mentioned about, the challenges in rural areas. Let's just take anesthesiology as an example. If there's not an anesthesiologist in the rural area, then it will be physician-led or surgeon-led or something. It will be physician-led, is my understanding. And so, in looking at that kind of standard and looking at the VA, I'm hopeful that we will, hold on to that standard to be in parity with what private hospitals are doing around the country. So, having said that, I wanted to ask this question on the ophthalmologist, around optometry and the ophthalmologist. The ophthalmology community, and you mentioned this just in your testimony about you don't intend on optometrists to be able to do laser surgery in states where it is not allowed. So it sounds to me as though you're planning on having a two-tiered system within this standard?
Thank you for the question. When it does come to looking at any clinician's ability to perform the services, it is based on that person's experience and licensure. With regards to optometrists, we do know that there are only 10 states currently that do train their optometrists to perform laser surgery. So transporting that skill for those individual optometrists to a location theoretically outside of those 10 states, allowing them to do that surgery could potentially happen. However, we would not be looking at those who are not trained appropriately who have licenses in the other 40 states. Again, this is all under review and consideration based on our listening sessions, based on our engagement with the entities who are here today on the first panel. We are including all of that information as well as a review of quality, access, and safety data to make our decision related to that.
And you are intending on that judgment call to be made at the medical centers across the country?
So the decision to allow a clinician to do a specific type of duty is based on their specific experience, and that takes place at each medical center. I myself am a physician. My license in Maryland says physician and surgeon. I am not proficient in surgery. My medical center would be required to determine what specific skills I can provide, regardless of what my license states. So it is an individual decision that is based on that particular clinician. It's based on their skills, their experience, and also their clinical outcomes. We do evaluate our clinicians through a focused and an ongoing professional practice evaluation, which allows us to know what we think they can do, and we can see what they can safely do and perform for our veterans.
Very good. So this is the second time that the VA has considered adopting a nurse-only anesthesia team. In 2016, veterans spoke out and strongly against the proposal, and more than 25,000 veterans commented in support of keeping anesthesiologists as the leaders of the team. The American Legion recently conducted a survey of veterans on the issue, the results of which it provided in a statement for the record in this hearing. So based on the Legion's survey, most veterans believe it's important for their anesthesia care to be provided by physician anesthesiologists, and they prefer a physician to administer anesthesia during surgery. How is VA weighing the views of veterans in the development of the national standards of practice for nurse anesthetists? What exact criteria will be used to make the final decision?
So thank you for that question. I'll start and then I'll hand it to my colleagues. But related to the American Legion survey, we did speak with the director of American Legion both during the development of the questions as the information was coming back, and then we did receive a preview of what the findings were. We do understand that our veterans are committed to having the best care possible. We would like to continue to work with them to explore what that means in all different care settings. Regarding the ability to make a determination related to the type of care that they're receiving, we want to make sure that we're providing care that is equitable, that is accessible, and that is safe. Dr. Saslow, would you like to add anything?
Thank you, Dr. Scavella. I think it's important to also recognize that we are not looking, and we've said it before, we are not looking at a nurse-only model. We continue in looking at the team-based models. As an adult nurse practitioner, even as an independent practitioner in VA, my goal is to make sure that I work as part of a team.
Excuse me, your time is up, thank you.
Oh, I apologize.
It was up when she yielded to you, so, which was inappropriate, but thank you. The chair now recognizes Representative Bergman for his questions.
Thank you, Madam Chairwoman. Just out of curiosity, you have those of you sitting on this panel who work at the VA, yes? And then you got the members of the first panel who basically don't work at the VA. They represent their, if you will, constituencies. Do you guys ever get together? And just, whether it be, a quarterly meeting, especially, let's focus, start just the AMA, because the overarching, institution with all the subspecialties underneath it. And you, as the VA, are the overarching umbrella, if you will, of all things, veteran and veteran health care. Do you guys ever, do you have routine meetings? Could you describe one?
Sure. So thank you for that question, Congressman Bergman. We have been engaged with several organizations, including the AMA, since 2021. We have dates of the over 200 engagements we've had with several different stakeholders.
Didn't it occur before 2021?
We do, but I can tell you that we've got dates in our files today that indicate that for this particular purpose that we have been engaging with the groups, including the AMA, since 2021. We do meet with these entities, and I think what we're hearing from them is they're interested in being a part of
So let me ask the question. Is ever, since you do have gatherings, has the question ever come up since 2021 that care in the community for veterans, has that ever been the subject of one of your gatherings? Because it's one thing to work in the urban suburban setting where you have the big VA medical centers and you have big civilian hospitals and surgery centers and whatever, but has there ever been any focus of a meeting on what it means to provide rural and remote health care for veterans in this 21st century?
So thank you for that question. Yes, we have explained that in some locations, due to the acuity of the facility, the types of care that's provided.
The explaining is not dialoguing.
Okay, I will say during dialogues, during meetings with these different entities, we've explained that we do have some concerns related to our ability to provide care in all locations where VA facilities or care.
Okay, well, I was kind of curious because when you have stakeholders in anything, and again, I think everybody here in the room believes why we're here is to provide better outcomes for veterans in healthcare. Are you aware, and this is for any one of the three of you, are any of you aware that in the 2016 APRN final rule that VA stated that CRNAs provide quality care and are able to practice independently without added risk to patient safety?
Yes, we're aware of that, and during that period of time, it was made by the administration, the decision was made by the administration at that time not to move forward with the full practice authority for CRNAs only, while the remainder of the advanced practice roles were given the full practice authority at that time.
Okay, well, since we are facing an ongoing shortage, workforce shortage across both VA and the private healthcare industry, especially in the rural and remote areas, how will restrict the services that certain health professionals can provide instead of allowing them to provide the full scope of services under their license do anything to help the problem? Are we unnecessarily restricting?
I'll start and I'll turn it over to my colleague, Mr. Callett. I think we want to make sure in any provision of services that we provide that we're providing safe care. So that needs to be evaluated closely to make sure that we're not providing anything that we think is going to be potentially a poor outcome for our veterans. So it's not an easy answer. It's not just a linear answer. It's based on a review of lots of factors. Mr. Callett?
Yeah, thanks. Excuse me. Thanks for the question. The idea here for the national standards of practice is to remove barriers. So if there are professions who, for example, require a referral before they can see a patient, like PT, eliminating that within the VA system would be our goal. The goal is not to limit top of license practice. So if you have a license that allows you to do more than what a national standard can do, there could still be leeway to do that. So we are not looking to restrict care, if I understood your question.
Okay. Thank you. With that, Madam Chairwoman, I yield back.
Thank you, Representative Bergman. The chair now recognizes Representative Budinsky for 5 minutes.
Thank you, Madam Chairwoman. I appreciate the input from all stakeholders on this important issue. My team and I have met with numerous stakeholders on both sides of this issue, and I'm particularly interested in how much of this effort will impact our rural veterans in particular. As we all know and have consistently heard, we are facing severe shortages of healthcare workers. Overall, and particularly in rural areas like those in my district, veterans in these areas most often travel lengthy distances for care, especially when seeking more specialized care. Professions such as CRNAs and optometrists often fill these gaps in most rural areas, which leads me to my first question to Dr. Scavella. Can you elaborate on the VA's process for these standards and to what extent the agency is factoring rural access challenges into your analysis of whether health professions such as CRNAs and optometrists' scope of practice should be broadened?
Thank you for that question. So yes, making sure that all of our veterans have access at all the locations where we provide services is extremely important to us. If you can't get the care, then the care is not, doesn't matter if it's great or not. So we want to make sure we are providing that care. In rural locations, we may have different challenges. Even in some urban locations, we may have different challenges with being able to provide the services that we need to provide. So we are keeping that at the forefront of everything that we're doing. Dr. Saslow or Mr. Callett, would you like to add anything?
So I think it's really important, and I appreciate the question about the rurality because we recognize that every state has rural areas to it. Our goal really is to try to provide the best and the safest care. North Star is always at our forefront when we're looking at the national standards for all 51 professions. And so I think the best take-home message is, yes, we are looking at exploring all of the opportunities as long as it is the national standard, not the minority of what we deliver in healthcare. So for those states that may be a smaller number providing greater access, we're not looking to restrict those particular states, but we don't necessarily want to see that care broadened across because it is not the norm for the rest of the country. Mr. Callett?
I wanted to mention another one of my top priorities since joining the HVAC committee has been working to ensure veterans have access to comprehensive behavioral health treatment as well. And that VA is keeping this as a focus in the development of these national standards. With that in mind, I noted the mental health and suicide prevention professions that would be included in the list of 51 occupations for national standards. My question, again, I'll start with Dr. Scavella. How do you see these national standards improving behavioral health access and suicide prevention efforts for our veterans?
So thank you for that question. There are several professions represented that do extend and perform care in our mental health or behavioral health settings, and that are able to both extend the team that's providing that care and also sometimes provide that care specifically. So we know that there are ways to expand the team by giving them more autonomy and ability to provide that care directly to veterans when it comes to suicide prevention and mental health care.
And if I could just add to that, I think it's really important, as Dr. Scavella pointed out, that several of the team members we already use, and we want to maximize that delivery, such as those with social workers, psychologists, and some of our advanced practice nurses, in delivering that mental health that is so very vital for our suicide prevention.
Yeah, thank you. Would you like to add anything? Okay. I think I have time for one other point in question. I wanted to turn to quality of care. We heard during the first panel that quality of care may diminish under these new standards, and both sides have cited studies that I think are important to factor into these proposed standards. I believe we do need some form of standardization, but I also want to ensure it's done in a way that does not harm the quality of care for our veterans, of course. Can I start again with you, Dr. Scavella? In addition to seeking public comments through the Federal Register, what other steps does the VA plan on taking to ensure veterans see improved health outcomes with these standards?
So thank you for that question. So one of the very nice things about the Department of Veterans Affairs is that we have lots of data. So we can look at healthcare outcomes and compare and contrast the care that our veterans are receiving. We obviously can look at the quality of the care being provided by different clinicians. By focusing on the work that they're doing, the work they've done in the past, and make sure that we are right-sizing and only allowing those with the skills, education, and training to perform those duties.
And I'd like to also add that one of the things that we recognize as part of the National Standards of Practice is that we have an obligation to look at the future state. And so as we roll out those National Standards of Practice as they are finalized, one of our goals in VHA is to look at the quality, the data, the outcomes, to make sure that what we are doing continues to have ongoing oversight. The national standards have to be reviewed and renewed or updated every 5 years at a minimum. But one of our goals is that should those standards need to be changed sooner because we identify opportunities or changes in practice across multiple states, we want to be able to have that ability to look at them up front and be able to address them sooner rather than later.
Makes sense. Thank you, and I yield back.
Thank you. The chair now recognizes Dr. Murphy for 5 minutes.
Thank you, Madam Chair, and thank you guys all for coming. I just want to say from the bottom of my heart, as a physician and a member of Congress, I have a very, very large contingent of veterans in our district, and I deeply appreciate your compassion and care for those who have served our country so well. Just a few questions. I gave kind of my thoughts about the scope of practice and the creep of the scope of practice because everybody wants to do what everybody did before and vice versa. It just gets in this absolute maelstrom of what's happening. Just a side note, Dr. Scavella, are you doing anything with, do you have anything to do with the electronic medical record? We had a hearing last week and it did not go well. It was everybody was very disappointed in the EMR that's going on in the hospital or with the VA system.
So no, sir, that is not in my portfolio.
Bless you. I think you're very lucky for that. But it spoke to me when you said we have data that confirms this, that, and the other stuff in the mind. That was one of the purposes of an EMR is to cull data. But if you don't have a functional one, I don't know how you cull data, really. I just want to kind of ask a question. Dr. Scavella, you noted that the VA has a plan not to move away from the team-based model. So if that's the case, then tell me how you plan the role of the physician in that, if it's team-based. How does that work?
So thank you for that question. So in VA, at times there may be different members of the team who may be the lead of the team. We believe that the team-based model is important. Majority of the time, it is a physician-led team, but there could be times where the physician may not be part of that team. So we're being broad with that terminology to make sure that we are able to be agile with the care we're providing.
Yeah.
If there's something that requires a physician will be there. But we want to make sure that we leave ourselves some room for that.
Sure. All right, well, thank you. I mean, I agree with completely. A physician doesn't have to be at everything all the time, and it's, the bottom line is we want to take good care of our veterans. I mean, I think that's absolutely, everybody agrees in the room, and I said this before, I'll say it again, that's the bottom line. Can you describe to me what the problem is that's trying to be solved?
Yes, sir. So thank you for that question as well. We want to make sure that if we have veterans who are entering our system in locations where we may not have the full complement of a team, that those people who are trained and confident in the needs of that patient, that they're able to provide that care.
Okay.
So that is the ultimate.
Sure, sure. I understand that completely. So where does community care fit in with that? Because I take care of VA patients. You know, when I was running a practice, we were part of the community care system. And, you know, I have a VA clinic that is literally 800 yards from the main medical center. So where does community care fit in that model? My question really centers around, are you going to send somebody out in the community that already has established scope of practice, residency, physician that has a fully recognized, fully established expertise in that field, or are we going to just try to keep them within the VA where their expertise and their scope of practice is not uniform, satisfied within the country?
So to answer the question related to how we're going to use community care, if we place a referral, our intent is always to see what our availability is within our system. We need to look at both the time length for the appointment, between the time desired and the time necessary for the patient to be seen, as well as how far they may need to travel for that care. So there are two different decision points when it comes to looking at how we get patients seen within our system or in the community. And those have to be evaluated each time to make sure that we're providing that care. We also use our technology that we have existing currently to determine if we are able to provide that care face-to-face or virtual if appropriate. So those are also factored into our decisions related to making referrals, and we want to make sure that we're doing what's best for veterans.
Okay, again, we want the best care for the veteran regardless of really what that looks like. And in the world of telehealth, in the world of community care, I don't think we need to degrade the care of our veterans in the term of, quote, access. I live in a very rural area, very rural, and we don't need to do that. I get concerned, and I'll just kind of say this for the record. Actually, I probably won't, but thank you. I'll be quiet. Thank you all.
And thank you, Dr. Murphy. The chair now recognizes Representative Landsman for 5 minutes.
Thank you, Madam Chair. I want to thank Dr. Murphy for his comments about the commitment and what you all do for veterans. Oftentimes we overlook that in hearings where we, want to get into the work, which is obviously really important. But I really appreciated the fact that is something we all believe, which is how hard you all work and why that matters so much. Just two questions, and then let you all answer them as you see fit. But one is on the listening sessions, and just sort of next steps, what to expect, what we should be looking out for. Will there be more, and what do you hope to achieve, and really just what are the next steps there? The second question has to do with this larger point about making sure veterans get the best care possible, which is obviously the goal that we all share. And we have competing thoughts, right? Folks from different communities are weighing in. Bringing them together to think through this seems pretty important to me, and I know that's been brought up. But thoughts on that, how that works, how that hasn't worked, but getting them in a room to say, okay, we all share the same goal of trying to, provide the best possible care. How do we do this together?
So thank you for those questions. For the first one, I will start and then I'll share with Mr. Callett. But we've held 4 listening sessions for the National Standard of Practice. We've broken up the groups of which entities were included over the past 4 weeks, all on Thursdays. The last one that is currently scheduled will be scheduled for this Thursday. And they've been really impactful, I think eye-opening to all of us on this panel. And we think the information gathered, because people have brought data, presentations, and other things to us, I think that has been really important and impactful to us. I'll turn it over to Mr. Callett for some more details on how we've done.
Thank you. Am I on now? There we go. Sorry about that. So after the listening sessions, the final one is scheduled for Thursday, and that will be the CRNA one. We expect to get a lot of information as a result of that listening session. We're going to need time to digest that information. We will then publish something in the Federal Register, send notices to all the states, and we've provided your staffs with a very detailed, just the high-level version of the process. After we get information from the proposals, where people tell us what they think we got, hopefully something that we got right, and what we didn't get right, we will then have to finalize the standard, publish it, and that's not where it ends, right? So once we do that, we are going to move to implementation. We're going to have a live link where we're hoping states will make use of it. If they notice for whatever reason during the process, they weren't able to get the information to us that they felt we needed, they'll do that. I did want to also just address very quickly the why behind this, because several of you have asked about that. Most professions are not going to experience a change as a result of the National Standard of Practice, and that sort of leads you to ask, well, then why are you doing it? The reason we're doing it is because those professions where there are slight variances can create administrative headaches that were noted as far back as the 1990s by the National Academy of Science. It's a problem for us. Things like requiring referrals or not allowing people to order studies, like chiropractors can't order imaging studies. These are the types of things, or audiologists to dispense hearing aids. This is really the target of the NSPs. Not the bigger picture issues exist, but they're not the prime driver for why we're doing this.
And to continue to answer your second question, which is related to how we can better bring together the groups, especially the opposing groups. I think our challenge has been that internally within our groups, especially the 2 corollaries that are represented here. So between our ophthalmologists and our optometrists internally, they both align under me. I've brought them together from day one. They've been part of this process. They may or may not be members of these organizations and may or may not be representing the organizations in their thought processes, but they've been together developing these standards from day one. Within our organization, anesthesia care, the anesthesiologists sit under me, the CRNAs sit under Dr. Saslow. From day one, they have worked together to put this together, whether they represent an internal VA professional group or one of these external entities represented today. They've been part of this process. So I think our challenge remains, and the fact that we are not necessarily as agile and as able to engage the presidents of organizations and to embed them in this work. And so we will need to work on how better to do that.
Thank you very much, all 3 of you, and I yield back.
The chair now recognizes Representative Van Orden for 5 minutes.
Thank you, Madam Chair. Apparently discretion is not the better part of valor, so I'd like to yield to my colleague, Dr. Murphy, as much time as he requires to say something that he will later regret.
The chair now recognizes
Not at all.
Dr. Murphy.
I only open mouth and change feet. But I'll just say this very quickly. Right now, in the state of California, 3 nurse practitioners are suing the state so that they can confront them when they interview their patients. They can be called doctor. It's very confusing, and this is one of my major concerns about scope creep, as it is. I don't think that's fair. I don't think it's right. I think it's inaccurate, and I honestly don't think most nurse practitioners would agree with them. That said, it is just something that I think we have to be wary about, of marching up the stream when there's so much of this scope creep. This really concerns me. I don't think that's accurate. I don't think it's fair. It's the difference between being a doctor and having a doctorate. So thank you. With that, I'll yield back to
Yes, sir.
Chair now recognizes Mr. Representative Van Orden for the remainder of his time.
Thank you, ma'am. It's Kellett, is that correct? First of all, thank you very much for coming, and Dr. Sasko and Scavella. It's interesting that Dr. Murphy and I are both struggling to read your names. We're talking about optometrists. Are there plans in place, and this is across the board, are there plans in place for in extremis situations? Some of us are from the Midwest, including the chairwoman. Suppose there's a snowstorm or a blizzard and the anesthesiologist cannot get to the hospital. Is that veteran going to be able to get medical care promptly?
So thank you for that question. Our goal is to make sure that we're there to provide the care wherever a veteran may come into the system. So whether there's a snowstorm or not. And perhaps I misunderstood your question.
Well, ma'am, I live in a very rural area, and we may only have one of the healthcare providers that are going to meet your national standard of care. I'm just going to say that right now, it's going to happen. So if we have one anesthesiologist who gets snowed into their house or drive off the road in a ditch in a blizzard, it happens every winter, will the veteran that is at the hospital waiting for surgery be able to get that care in a timely manner?
I'll yield to Dr. Saslow.
So I think it's important to recognize that whether it's a snowstorm or a hurricane or an earthquake, one of the things that we try to make sure facilities recognize is how they prepare their staffing models in order to be able to meet the demands of the veterans when they're coming in. And should those types of events occur, how do we make sure that we're maximizing the care delivery to that veteran? So it really will be dependent upon the facility to prepare the right model in order to make sure that they're meeting the needs regardless of the issues that arise.
Well, I understand that, sir, but rocks are heavy, trees are made of wood, and gravity's real, and we've got one anesthesiologist. So if there's a qualified nurse anesthetist who is on station and the anesthesiologist is in a ditch, will he or she be able to give the appropriate medical care to that veteran in a timely manner?
So
it's a very, very simple question.
yeah, it depends. Unfortunately, it does depend. If the one sole anesthesia provider that is available is not capable of providing the care that's provided, it would not be something that we would want to see. We would want to make sure that that veteran is receiving the appropriate care from a clinician that can provide it. So in those instances, it may be a matter of delaying the procedure if it's elective. It may be a matter of sending them to another facility where there's the appropriate care that can be provided. It can be a matter of waiting if it is elective. If it's an emergency, there's a different situation.
Doctor?
Yes.
Ma'am, may I ask where you're from?
I grew up in Chicago, Illinois.
Okay, so you've been in a blizzard.
Correct.
Okay, and I want my hair to grow back. It ain't happening. So I'm asking you a real simple question. We have a qualified nurse anesthetist on station. You can't send somebody to another facility because there isn't one where I live. Or it's 60 miles away and it's 35 degrees below zero and you're in a snowstorm. You physically can't move. You got a patient and a qualified nurse anesthetist on station. The anesthesiologist is in a ditch. Will that man or woman who is qualified as a nurse anesthetist be able to provide adequate health care, timely health care to that veteran, yes or no?
So Congressman Van Orden, your key word is qualified. If that
Back it up.
entity is qualified,
Sorry, go ahead.
if that person is qualified to provide the care that is being requested and needed, then that person would be able to provide that care.
So a qualified nurse anesthetist will be able to administer anesthesia to a veteran in extremis without direct supervision or supervision, even a phone call, because phones don't work, in extremis.
So again, it depends on the care that's being provided, and it would be a case-by-case basis. Sorry that I don't have a better answer, but to give a blanket authorization to provide care just because you have a body does not necessarily mean that you can. Same thing for an anesthesiologist or a physician.
Yes, ma'am, I understand. My time's expired. I want to say one more thing. I believe that this model may be too rigid, and there must be things written into here to provide for that exact scenario, because it's going to happen in Dr. Miller Meeks' district just as mine. Thank you. I yield back.
And thank you, Representative Van Orden. The chair now recognizes Representative Scott if he wishes to have questions for 5 minutes.
Yes, I would, and thank you very much once again, Chairwoman Miller Meeks and Ranking Member Brownlee, for your kindness in allowing me to be a part of this. Ladies and gentlemen, we are at a very critical moment in time. in our nation's history, in the way we care and express publicly about our thoughts, our feelings, for two groups. One group are our veterans. No other group is having the massive suicide rates as our veterans. And a large percentage of those suicides come from inadequate health care in our VA system. And now with this movement to try to now turn over the basic element of medical treatment away from the doctors of anesthesiology to the nurses. Think about that. The other group are our law enforcement who put their lives on the line. Both groups out there willing to pay the ultimate sacrifice for our protection and our growth. And they are worried about what we are discussing here today, their health care. Now, I want to direct my questions to, this time, to both Dr. Scavella, I hope I got that right, and Dr. Saslow, if you could answer these questions. The VA's previous process was transparent and included all stakeholders. It resulted in the right decisions for our veterans. However, this current process lacks any transparency. A small work group has been tasked with working on this proposal, all behind closed doors. So my question to you is this: why is this process so secretive?
So thank you for the question, Congressman Scott. We have been including our individual specialists in the area of each of the 51 occupations on the working group, and we have been engaged with stakeholders since 2021 related to this specific work.
Well, let me ask you this. What assurances do we have that the work group includes subject matter expertise from all key stakeholders, including frontline VA anesthesiologists?
So thank you for that question as well. We have included our frontline anesthesiologists and CRNAs, as well as other advanced practice nurses and physicians, specifically for the work that is beginning for the National Standard of Practice related to anesthesia care.
Well, let me ask you this. Can you and Dr. Scavella, I believe, did I get that right?
I'm Dr. Saslow, but that's...
Okay, Doctor, I don't want your colleague to have to be by herself in answering these. This is important. The eyes of the nation are on us. And finally, we're dealing with this issue of veterans. Answer me, can you list, either of you, who currently serves on the work group?
So thank you for the question. I think it's really important to recognize that with each of the different 51 professions that we're working with, we have multiple professions within that group that are sitting on those work groups. We also go back to those work groups as they're developing, because we're not, the concept of it is a small work group is not necessarily as accurate as it might sound. The larger work groups of those particular professions are the ones responsible to come in and work with us to identify what opportunities for standardization exist amongst each of the professions. And so we hope that it is a much bigger participation than what you may have already been alluding to. Thank you.
Well, my time is up. Once again, thank you very much, and I appreciate this. We have a bill going forward to make sure we keep our anesthesiologists as the primary source for treatment in this area. And I appreciate you all having me as a guest. Thank you very much, and thanks to the panel.
Thank you, Representative Scott. The chair now recognizes herself for 5 minutes. The reason we're having this hearing is actually because of comments that you've made, Dr. Scavella. We're having this hearing because multiple groups approached members of the HVAC with complaints that national practice standards were being developed and they did not have access, nor were they communicated, not in email, not in phone calls, not in meetings. So we had a roundtable in April, as Ranking Member Brownlee mentioned, and we found further at that roundtable that allied health professionals or non-physician health professionals, and to be clear, I do not consider an optometrist a physician, and I'll ask a question about that in a moment. However, we found that non-physician groups had great access to the VA, but physician groups did not. And you specifically defended yourself by saying, within our organization. And let me just say, when you're an employee of an organization, which I have been, both in my 24 years in the military and as an employee, a physician employee of a hospital, and as a nurse of a hospital, you are sometimes muted in your responses because you are talking to your employer. And if you feel your employer wants to go down a certain track or pathway, you may not relay your true concerns or feelings. The other thing that I'd like to mention is something I think that gets confused, and it's often brought up in scope of practice issues within states and state government, is that often the rationale for expanding scope of practice is so individuals get care in rural areas. As we found when Oklahoma passed their laser law for optometrists, looking at CMS data, the majority of laser procedures were, guess what? They weren't performed in rural areas. They were performed in the metropolitan areas of Tulsa and Oklahoma City, and that exists to this day. So can you tell me how many VA hospitals are located in rural areas? How many are in rural areas?
So Chairwoman Miller Meeks, thank you for the question. I would actually have to look at a map and count. I don't have a breakdown of those that are specifically in those locations.
They may be in rural states, but in a rural area of a state. So in Iowa, our 2 VA hospitals are in Iowa City, where the University of Iowa is located, and in Des Moines. There aren't any facilities in a rural area. There may be clinics. So if, as you alluded, if you were to allow an optometrist licensed in Alaska, as Dr. Barney said, he's licensed in Alaska and can perform laser procedures, to then come and be located to the VA hospital in Iowa, even though there's ophthalmologists, that optometrist would then be allowed to perform a procedure for which he is not licensed to do in Iowa. Is that correct? I think that's what you stated.
Theoretically, just like my license is transportable across the country, I can operate in any federal location. That would potentially, if we were to make that decision, that would be something that we would look at for quality reasons, but potentially.
Which is why it's tremendously concerning. So, Dr. Scavella, are non-physician providers required to identify themselves as such to veteran patients? How does the VA educate veterans as to the qualifications? When a veteran, or for that matter, the public hears doctor or physician, they think that this is someone that has gone to medical school. Are you going to inform veterans that the person treating you has not gone to medical school, has not done a residency, is not board certified? And in fact, to get on the insurance of most health insurance providers and Medicare, you have to be board certified or board eligible. Are CRNAs, are optometrists, are other allied health professionals that you may increase their scope of practice to practice in a state for which they're not licensed to do that, are they board certified and board eligible? So how is it that you intend to, number one, address what the American Legion said when they would prefer to have a physician, and how are you going to use lower educated, lower trained providers in lieu of having someone go out into a community for care when there is a provider that is a physician provider in that community?
So thank you for that question. We would always want to make sure that we're providing the highest quality care for the veteran and the needs that that veteran was having at that time. Related to how clinicians identify themselves to veterans, it is our understanding that they introduce themselves and explain where they are as part of the care team.
Which is exactly why we're having this hearing and exactly why, as a nurse, married to a nurse, as a doctor, as a veteran, I'm concerned about the secrecy, thank you, Representative Scott, the secrecy of the VA in going through this procedure, their lack of engagement with other groups and other providers until you have an open comment. I know that you're having listening sessions. I thank you for doing that, but I would say that my concerns have not been allayed, that we will be providing our veterans the highest quality care by care teams led by physicians, and that patients know whether or not a physician is delivering care or another individual of other education and training, as knowledgeable as those individuals may be. I have great respect for everyone in the healthcare profession, but I'm very concerned about what's going on. The chair would recognize Ranking Member Brownlee for any closing remarks.
Thank you, Madam Chair. I will say I served in the California legislature, and whenever there was a committee hearing on scope of practice and licensing, you always knew it because there were crowds of people outside of the hearing room that couldn't get into the hearing room, and there was a lot of debate going on outside of the hearing room. So I know that these are very, very difficult issues to settle on. So I will say that based on this hearing, I feel as though we're getting closer to better clarity from the VA on whether a team-based model of care means a physician-led team-based model of care. So I think the answer from the VA was most of the time. Most of the time it will be a physician-led model of care. So I will say in regards to that when we compare the VA to those hospitals outside of the VA, that's not their model of care. And I don't want to give up quality under any circumstance. And I think we heard also today that even in rural hospitals, and I think Dr. Miller-Meeks's point of there are no hospitals in rural areas is a very good one. But even in those rural hospitals, if they are there, we've been told that it's always a physician-led care team. So it might not be the anesthesiologist, it might not be the ophthalmologist, but it is a physician-led team. So I don't want to give up quality, and I don't want to be less than what other hospitals are doing outside of the VA. I will say again what I said in my opening comments, and that is to why the VA is doing this initiative when, at the end of the day, the medical professionals at each medical center will ultimately make these decisions. Now, the VA said we still have to settle some of these discrepancies between different practices. But at the end of the day, it is still going to be the medical centers and the professionals therein who will ultimately make final decisions on who will be performing what and scope of practice. So the VA has also said we need more agility, and I understand that, but even when the VA provided more flexibility of scope of practice during COVID, the VA has told me unequivocally that the practices and protocols never changed, regardless of the emergency. So even when they were given that ability to be more agile, it was not utilized. And I have to assume that those decisions were based on the quality of care. So I will just end by saying, I think what other members have said on the committee is the VA should never give up, ever give up on delivering the highest quality of health care. Our veterans have complex health issues, and they should receive the highest quality of care. They should deserve no less. This is what we owe our veterans, and I hope as we proceed in the process of this that we will keep the highest standard of care. I yield back.
And thank you, Ranking Member Brownlee. I'd like to thank everyone for their participation in today's hearings and for the productive conversation. I know this is a challenging topic. I've been involved with it at the state level as well as here at the federal level. And the passion for your work and your care for veterans is evident to us in both of our panels. I appreciate everyone's willingness to come here today and to focus on what should be our utmost priority of putting veterans first. It's important to me and to my colleagues on both sides of the aisle that all veterans seeking care in the VA are ensured quality care that is safe and effective. And I look forward to continued work on this effort to create equitable standards of practice across the VA, within the department, stakeholders, and my colleagues on this subcommittee. I will echo again that the nature of care in rural areas when it comes to a VA hospital facility needing providers is very different than what it is within a state or a district. I would also like to say that the workforce shortage that has been mentioned, last year we passed a bill to increase the pay for nurses, nurse practitioners, PAs, and allied professionals because there was a shortage of those. So I think to proffer an idea that there is a physician shortage, so we need to replace them with others would be inaccurate. I'm going to also echo a statement often made by VA officials that the veteran population is unique. They tend to have more complex health issues with multiple comorbidities, resulting in a higher risk of complications. Let's not forget that when considering policies that may have a significant impact on the care they receive. And let's also remember that we have a Mission Act and community care to address some of the issues in where veterans can receive care and in a timely fashion. The complete written statements of today's witnesses will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objections, so ordered. I thank the members and the witnesses for their attendance and participation today. This hearing is now adjourned.